Right. Good. Okay. You, today we are going to do four topics, right? Now, first two topics, I will basically do the normal way of lecture. In the last two topics, I want you all to find out balance. Okay, I mean this thing, and then we will discuss. Anybody knows where this is? Nope. Ever been to your travel? Go from where? What's up? Where you? What the? Ah, there you go. एक उंगट is near to. Anybody know where it is? No. This is where the Mahavali Ganga gets into the idea. You can see that's the Mahavali Ganga coming. And there is a bridge actually. This was destroyed during the war. And then it basically flows into the sea. That's called Lankapattu. Lankapattu, there's a nice vihara also. Supposed to be this place over here is a huge bay and a nice virgin beach. And those days, this was the port, and all the ships came into Sri. That's why it's called Lankapatuna. And then there is a legend saying that the sacred tooth cleric was walking by Himalaya. So, and now it's like that, and it's we will go there. This beach is wonderful, very virgin beach, and if you travel, it's basically in the east. You go further down, you can go to Akare and just to make your interest. You can like now be a comment. Come here. Right. We are going to, as I said, start off with two. Today, the main this thing is autoimmune diseases, connective tissue diseases, and the eye. So these autoimmune means normally we have an immune system. So where there are antibodies produced against antigens, and this immune system is the one that basically protects us. So autoimmunity means, unfortunately, the immune system doesn't recognize that they are foreign antigens. So therefore, the body itself produces antibodies against yourself. And that causes diseases. And we are going to talk about four of those. And the first two, I will basically tell you. The first one is rheumatoid arthritis. Have you ever heard of rheumatoid arthritis? Seen people with rheumatoid arthritis? It's basically affecting the joints. Rheumatoid arthritis means the bones. Itis means inflammation. So an itis in any place is an inflammation. So it's a chronic autoimmune disorder where it causes inflammation of the joints, these joints, and they get swollen and they treat. So that is rheumatoid arthritis. There are causes and risk factors. If your family members have rheumatoid arthritis, then you have very good chance of getting rheumatoid arthritis. It's more common in females, and there is a relationship to the hormone estrogen. So since the females have estrogen, it seems to be that it's more common, and they develop in the adulthood, say between 30 and 60. And some of the environmental triggers is that smoking. Smoke, you have a chance of getting, if you are genetically predisposed and you start smoking, you might get rheumatoid. So these are the risk factors, and this is how it affects the joints and causes inflammation, pain, and stiffness. And there is swelling. And it comes in bouts. That means it starts swelling and then it goes away and then it comes back again. Right? And then ultimately, when the joints start, they basically produce this type of deformity where you cannot, very painful. So if you take a normal bone, these are two bones, and that is the joint, right? Normally the bone, they say it's the knee joint, and this is the top bone, and the one is the bottom bone, and there is a capsule that basically covers the joint. And inside and then lining the two bones is the cartilage. And in between the two, there is a jelly-like, and that is called synovial fluid, which is produced by these cells, and it's like a jelly-like thing which prevents the friction between the two. And then and apart from that, there are blood vessels and lymphatics which basically cover the joint. That's how it's normally is. Then, if it gets inflamed, right, it becomes like this. See, the synovial, the covering has become all swollen up. And there are inflammatory cells that come in, and then they produce all kinds of stuff to basically cause this. And then it also produces these cells called osteoclasts, which basically erodes the bone. So not only is it getting inflamed, the bone is also getting eroded. So the whole thing is basically uh, mediated by these these antibodies, which one of which is the rheumatoid factor. And then there is anti-CCP, and then there are immune complexes that basically the antigen antibody complexes come and then get deposited over here. So all these things causing inflamed, become swollen and inflamed. So it's normally affects, say, if you take the two hand and both hands are normally get it's the neck. It's the two knees, both knees gets affected. And the other thing is, it starts with the small joints, and later on it goes into the larger joints. So, and you feel in the morning is the one that you feel basically stiffness. You cannot get up, and all these things basically you cannot uh, the, move the hands, and you feel tired. And sometimes in the night you develop fever because of that. And if it keeps on coming like that, the as I told you, the joint becomes deformed, and this is how it looks. It's multiple joints, symmetrical. It has the two hands, or the this thing. So it first occurs in the small joints. Small joints means if you take the hand, it's funny because it basically affects the proximal metatarsal joints, these two joints, but it spares the last. I don't know why that happens, but that is how, and therefore you get a deform, right? And then later on, as I said, it affects the larger joints as well, and the elbows, the knees, the ankles. And as I said, it flares up, goes down, and comes back. So there are triggers sometimes that basically people who have rheumatoid arthritis know, either it's the environment or something that comes out that flares the inflammation. So how do you diagnose? Now, as I said, there are antibodies against yourself, but mostly it's you take a good history. Basically, you ask the patient, your family affected, have you had this type of thing before? And then you do an examination, and then only you start doing the blood test. And these are the two common blood tests that we do, the rheumatoid factor and the anti-CCP antibody. So basically, you do the rheumatoid factor. You don't have to be positive, but some people are negative in the rheumatoid factor. But then there are these common inflammatory markers, which we call the erythrocyte sedimentation rate, ESR, and the C-reactive protein. These are elevated mostly. So that is how we monitor whether you are basically actively having this inflammation. Then obviously when it becomes very deformed and things like that, we do the X-ray, and you can see the X-ray here. The joint has basically, you know, eroded and it's deformed, and that type of thing is the one that we use. We do the X-rays, the ultrasound, and sometimes then MRI. So that's how we basically diagnose, and it's mainly a clinical diagnosis. You can ask the patient and you can ask the history, how it comes and goes, and then with that you make the diagnosis. Then how does it affect? Yeah. There are two ways, just remember this. There are two ways that rheumatoid arthritis will affect the eye. Rheumatoid arthritis itself will affect the eye. And the most common thing that rheumatoid arthritis causes in the eye is dry eyes. Can be very mild dryness. And then it goes into a very bad dry eye, you call it keratoconjunctivitis thicca. And if there is a syndrome called Jerkron syndrome where it becomes so dry that it becomes. So just remember that rheumatoid arthritis, if somebody comes with dry eyes, ask them about the first thing that you ask about that. Then it can affect the sclera and the episclera. The sclera can become thin, and there may be uveitis and iritis, and later on they can basically cause a cataract. So the dry eye is the most important thing, which the rheumatoid arthritis is directly correlated. So this is a patient, we normally to check whether a patient has dry eye, we stain the cornea with fluorescein. And these green parts are the fluorescein, and you can see the tear film, the fluorescein is basically showing up, gradually increasing, and you can see a severe dry eye over here. And these are also mucus plaques. This is classic dry. Keratoconjunctivitis, PICA, is the dryness that occur. And when it becomes so dry, it looks like this. That's the dryness. The epithelium has basically gone off. It has caused basically a corneal ulcer. And when you stain it, you see the ulcer like that. That's severe, right? So rheumatoid arthritis, dry. Just remember that. Okay? And it can be mild. Then, if it goes on and on and on, they might develop different things. Let me tell you about one of my patients. This is Shant. Shanta came to me when he was around, I think, 15 years. In small days, he had had an injury to the left eye. And that eye, basically, I still can't see. It's blind in that eye. And then he started developing red eye in the. This is just before his O levels. I can remember he always came with his mother, still does. And then it became so bad that the vision also went down. And then he had to basically, I have been telling him to do braille, but he never get on to that, went on to do that. But with the greatest difficulty, he managed to do his O levels with this little bit of vision. These come and go and come and go. And then he developed basically the eye becomes very red and the sclera becomes very, very thick. And that is called scleritis. Extremely painful. It comes and goes and comes and goes. Now, being then that also developed a cataract. You can see that the cataract is there. So there is uveitis, there is scleritis, and the sclera is thin because you can see the choroid, the dark part is the choroid. Choroid is just showing up in the bottom. So, so he developed scleritis and now he's basically blind. But he's a very good musician. He always tells me, I'm going to be a star. So he's always comes with the mother and then he can play the organ, wants to upload things to YouTube and all kinds of things. But still, but he is well. There is a pan uveitis. So basically, the whole of the eye, that eye is also gone. He's basically blind. And that's why, and the worst part is sometimes he gets very bad pain and redness. And now you can see he has developed a cataract. You can't go and do this because the screen, you can't do a cataract this thing because there's so much of uveitis. And because of that, you cannot go in there. So that is Shant. So the other company, so I told you that rheumatoid arthritis causes dry eye and it can also lead on to going to do scleritis and things. The other complication is that we treat these patients with certain drugs, and the drugs have side effects. So the side effects causes problems when you so one is directly the patient has problems due to rheumatoid arthritis. That is the dryness and the scleritis. And the other thing is due to the drugs. The main drugs that we use is steroids, corticosteroids. I'm sure you would have heard that when you use corticosteroids for a long, long time, it has its own side. Can cause glaucoma, it can cause cataract, can cause so many other things. Your immune system basically goes down. Then there are non-steroidal anti-inflammatory drugs also. But the most common thing all the rheumatologists use is this thing called hydroxychloroquine, HCQ. Now, HCQ is given for a long time, sometimes years and years and years. And whenever the rheumatologist starts on HCQ, they basically send this to us to check the eyes. And they develop, in certain very small percentage, they develop a macular. HCQ can cause a macular, which is irreversible. I mean, once you lose that. And then there are other drugs, methotrexate and all kinds of TNF inhibitors, all kinds of other drugs that they use, but they hardly use. But this is the one they basically use. I don't know why I get so many even after this chikungunya business. It's like chikungunya, after chikungunya, you get joint swelling. So they give hydroxychloroquine. Hydroxychloroquine is the culprit, but they say that the British rheumatology association, they say that you don't need to see them very often because hardly ever. What they say is if you give them 5 milligrams, less than 5 milligrams per kilogram body weight, it will take at least 5 years for them to develop the maculopathy. And this is how it looks like. Chloroquine retinopathy or chloroquine maculopathy, because chloroquine goes and binds to the melanin in the retinal pigment epithelium. And that's how it causes these problems. And it can be, that's the macula. It can occur around the macula, the maculopathy, or it can be very central over there. All this area is affected, or it can be a combination of perimacular, parafoveal, and pericentral. So that's how it looks like. But I just basically want you to know the normal thing way that they come. This is how it looks like. That's the disc, and this is the macula, and you can see depigmented patch in the macula, and there is loss of vision. So that is hydroxychloroquine maculopathy. So I told you 2 ways that the eye gets affected with rheumatoid arthritis. One is directly with dry eye. Second is due to side effects of eczema. So those are the 2 ways that the eye gets affected. And these are just the same, another 2 examples. This is the right eye and this is the left eye. And you can see the maculopathy in both eyes. And if you do a visual field, this is how it looks like. There is lots of, this is the macula over here for the fovea, and there is lots of vision right round, like that. This is the right eye and this is the left eye, right? And if you do an OCT, it looks like this. OCT is also, you can see paramacular scarring over there and over there. Even in this, it's like that. So most of the time, the macula is spared a little bit, but still for all the vision is down. And then the way to check it is the easiest way is to check with the abstract read and then also check the color vision. So HCQ maculopathy occurs in rheumatoid arthritis if they are treated with hydroxychloroquine. Then the other treatment modalities are basically we give them physical therapy. Some kind of mobility is always necessary than keeping the joints, stay. When they are strained, they don't move the joint, and then it becomes more stiffer. And then to do a little bit of exercise, and then joint protection in the sense to wear a knee guard. And then obviously a healthy diet which contains less amount of animal products and less amount of oil and salt. And obviously to quit smoking, because if you are a smoker, the chances of you getting rheumatoid arthritis is more. And even when you are having rheumatoid arthritis, if you start smoking, the swelling comes on again. So it's always best to ask them to quit smoking. Then when everything, all those things fail, we do surgery, which is the last thing that we do, is to basically, if the knee joint is basically eroded, you do a knee joint replacement, and you can do all kinds of other things. Tendon repair, sinus repair. Those are done by the orthopedic surgeons. So before getting all to that, it's always best to, you know, give them these lifestyle changes and protect them. The minimum amount of drugs the veterinary. Some people basically don't even go for this because they feel that I can just manage with uh, a painkiller, even Panadol or something, and then they go in for Ayurvedic treatment with the oils and things. They are pretty good. Then, because as you can see, once you start using HCQ, and later on, if by any chance you develop maculopathy, that is not because. So that is rheumatoid arthritis. And then we come to the next part. What do you see? The next disease. Anything wrong with the face? Yes. What is it? Normal face? Or there's something here on it? Can you see that? What is it? It's a kind of a rash, isn't it? Yeah. And it's called a butterfly rash. Butterfly in the sense it looks like a. So the disease that causes this type of thing is called systemic lupus erythematosus. In short, we call it SL. It's a chronic immune disease and it affects all most of the organs in the body, including the eye. So systemic lupus erythematosus. And the moment you think about that, you look at the face. If a person comes with this type of problem, just observe, see whether it goes, it can go into the forehead and then the cheeks. And that's called a butterfly rash of systemic lupus erythematosus. So as I said, it's an autoimmune disease. It attacks there are immune antibodies that attacks its own tissue and leads to inflammation, just like in rheumatoid arthritis. And you can see the butterfly rash very well here. It's affecting the forehead, the nose, and then coming onto the cheeks, the melon. So it's like a butterfly. Can you see that? So and then it can affect the lungs. In the case it affects the lungs, you call it a pleural, you can get fluid in the lungs. It's called a pleural effusion. The heart, the pericardium, the covering around the heart can get affected. That's called, then you may lead to all kinds of heart failure and things like that. It affects the kidneys. The complexes go and this basically get deposited in the kidney. You call it lupus nephritis, and obviously the arthritis, the joint. And there is a phenomenon called Raynaud's phenomena where you find the blood circulation into the distal extremities becoming less. So this is what happens in SLE. It affects all these organs. And the main thing I want you to remember is the butterfly rash. So as I said, there are so many pathophysiological reasons for this. But the most common thing is that loss of self-tolerance. That means the immune system fails to recognize self-antigens. It doesn't recognize its own antigens and it starts producing antibodies against them. Then all these immune complexes, they go and get deposited. And there is another thing called the complement system. And that's also part of the immune system. And the complements, the number of complements goes down. And then there are genetic, hormonal, and environmental factors. As I said, the estrogen and the ultraviolet rays, those can basically exacerbate SLE. I've got 2 or 3 patients who are basically having nephritis. They basically don't get treated here. Sometimes they go to their one or two engineers also. And they, when they get exposed to the sunlight, they get a rash pattern. And then it affects all these, the kidneys, the skin, the lungs. It can occur in the brain and mostly the heart. So all these things can occur, and that's the pathophysiology's main thing is loss of self-tolerance. That means the immune system fails to recognize its own antigens, and then we produce antibodies. So that is the pathophysiology of systemic lupus erythematosus. So how do you find it? There is a gamut of investigation blood tests that we can do. The most common thing that we do is the anti-nuclear antibodies, and then anti-DS, DNA, and then anti-SM. Then the complements, I told you the complements go down. ESR and the C-reactive protein goes up. And then you do a full blood count, you can see anemia. And you check the urine, there may be protein in the urine, and then you do the renal function tests. These are the basic tests that they do when you have systemic lupus. You can do other tests also, like skin biopsies, kidney biopsies, and then take X-rays to find out whether the heart is getting affected. Do an ECG and an MRI. So these are the ways that we basically do the blood test, and then you're convinced. If you're not convinced, you go ahead and do the other tests. Those are the investigations that we do. Lupus erythematosus. Treatment. As I told you, sun, you have to provide them with protection from the sun. UV glasses, UV everything. There are skin lotion that protect you from the ultraviolet rays. And stop smoking, lifestyle changes, a balanced diet with exercise. And there are certain vaccinations that you can do. And then you start treating. Basic thing is that we have pain. Therefore, we start off with a non-steroidal anti-inflammatory drug, which is Brufen. I'm sure people know that. And then again, they still use HCQ, hydroxychloroquine. And they also start on prednisolone, which is a corticosteroid. And then there are immunosuppressants, biologics, cyclophosphamide is another drug that we use. But basically, anti-pain and chloroquine and steroids. Those are the things that they use. So that is the treatment for SLE, but it's a very chronic disease. Goes on the whole of your life, it's like that. But these are things can be done without any, so it can prevent the exacerbation. So the key points, the things that we basically gets affected, as I said, you get this rash. The moment you say systemic lupus, you look for the rash. The eye can get dry eyes, and the lungs can get affected, the kidneys can get affected. And in certain patients, the hair falls out. It's called alopecia. And then there are blood tests because the anemia, the blood count goes down. Then you can check the heart and also the hands. So the cause is an autoimmune multifactorial disease, SL. And it affects the skin, the joints, and all these organs. Diagnosis is basically you look at these features, whether it has a rash, can come on the rash, can come on the back as well. And then you customize the treatment accordingly, whether it is pain, you give them non-steroidal, and then basically the prognosis is variable. Sometimes they go on for remission for a long time, and then all of a sudden it comes back. So that is systemic lupus erythematosus. Good. Now we come to the quiz time. Good. Quiz time in the sense that now we are going to do another two tests, two topics. This time I want you all to get your cell phones and three, four, one, two, three. We get into two groups, right? That's good. Now. So get two groups, and I want you all to find. It's in the this thing. I want the next two topics are one is giant cell arteritis, and the other is herpes zoster ophthalmitis. Let's start off with one. I want you all to go on whatever the search engines you have and then find the answer to these subtopics. In giant cell arteritis, just find out what it is and then what is the pathophysiology, what are the symptoms, the investigations, and the treatment. There's one important thing about giant cell arteritis. It causes anterior ischemic optic neuropathy. So it's Google time for all of you. Go on and check whether you can find some answers. Good. ඒකට බෙදලා මම පස්සේ I just want you all to basically tell me. I will come and write it down or just tell me what you all can. Good. දෙකකට බෙදාගන්න කොච්චරයි? හතර හතර. So this class, one person finds one, the other person finds the other, and then we will see what you all find. Almost තියෙනවනේ හැමෝටම. The first topic is giant cell arteritis, GCE, and it is also called superficial temporal arteritis. boleh mah dia kan sudah mesin. What some topics මේක දාලා තියෙනවා. කරාට පස්සේ ඔය හර දෙනා ඩිස්කස් කරමු. Compare your answers with one another. Very large details just point forms. Then discuss with the others and see what they have also found. Okay. But I don't want large answers. So simply. ಇದಕ್ಕೆ ಉತ್ತರ ಬೇಕು. Nanti ya. Good. Okay. Yeah, good. I have to come and feel the rest of the thing. Our cow is happy. Anybody? Yeah. एक ऑफ कर लो आंसर। Okay, that's very good. And I hope you all got the idea of what giant cell arteritis is. Basically, when you mean arteritis, it's an inflammation of the artery. So, itis means inflammation. So, if that is the artery lumen, it basically gets inflamed inside and it becomes smaller and smaller and smaller and it gets occluded. So the inflammation is inside in the wall. So there is a granulomatous inflammation of the medium and large arteries and the whole thing gets occluded. So if it gets occluded, what happens? The blood supply stops. Blood supply stops means basically you lose supply to whatever the area that is being supplied. And then so the giant cell artery inflammation condition, large blood vessels was anterior ischemic optic neuropathy. So if the optic nerve blood supply gets affected, all of a sudden you get an sudden loss. And that's why you get sudden painless loss of vision. All of a sudden, cut the pain down. Then this is the other thing that they present with these things, which is quite right. They present with this the temporal artery becomes very thick and thin, so they get scalp tenderness whenever you hold that place, and it's always in elderly over 68 to 80. And then you get the jaw claudication. What do you mean by jaw claudication? When you open and close, you get teeth, right? And then, so there is acute loss of vision. And as you say, ESR is very much elevated. Elevated means it's more than 60. And if you get a more than 60 ESR with all those things, then you are pretty sure that it's a giant cell artery. And then the C-reactive protein is elevated. And the other thing that you can do, which we normally don't do, is that we do a temporal artery biopsy. That means we take a small part of this artery and then see whether it's inflamed. So that is so the ESR is elevated E-reactive protein is elevated, and you can do a biopsy. And then, when you do the biopsy, this is what you see. The lumen, this is a cross section. You can see the whole thing is obliterated. There is no blood going through that. So there is, as you say, a granulomatous inflammation of the medium and large arteries. And there is a disruption of this internal elastic lamina. And then there is no blood supply. And if you take a larger look at the histology, these are what we call giant cells. It's a large cell with a lot of nuclei. So in large, high magnification, you see these. That's why you call it giant cell. Giant cell කියලා කියන්නේ. So it's a giant cell arteritis, and it occurs in the temporal arteries. Therefore, we call it a superficial temporal arteritis. And quite correctly, why is it important? Because if you don't treat it at that moment, and if there is a uh, occlusion of the lumen in the causing a anterior ischemic optic neuropathy in one eye, the chances that it will get into the other eye is very much. So if you have high ESR, sudden loss of vision, and this all these things, you immediately have to start. If not, that's why we call it a ophthalmic emergency. That is why it's important to diagnose this a clinical diagnosis. A big issue. Become elderly patient, pain here, and do an PSR and see. No. And then immediately you start off this high dose of corticosteroids. So severe acute loss of vision treatment is steroid to protect the fellow eye. Most of the time it's bilateral. And if you look at the fundus, there are small sphincter hemorrhages. Disc is very pale. And basically it goes into optic atrophy and you lose vision. So that is called anterior ischemic optic neuropathy. So the treatment is high dose of steroids, intravenous. And you immediately with that, and then you tailor it over the time with oral steroids, and then you check the ESR and the C-reactive. Good. Very good, very good. You all have done your work all right. Remember these things because it's a ophthalmic. Shall we go to the next one? That's the next one. Go ahead. This is very good, huh? I'm really impressed. This again is a spot diagnosis. You see this, you can't miss it. Trying to get a pair of gloves. Very good pair of gloves. അതിന്റെ എങ്ങനെ Yes. Lateral limit, lateral limit one thing. Right? Right. Compromise. First and second, felicidades aos para sempre. Seguia learning to get photo check. Big what is such? I kill somebody else can't. What are the complications and the very simple. Anybody has had the chicken pox? Anybody card? Nobody? Yes or no? No? Eh? Why? Then you are very much, you first get chicken pox and then you get your pilgrims. You cannot go near a patient with that person who has not got chicken pox. You go near a patient with herpes, you get chicken. Have you all got your eyes checked? Yeah. Body. Exhale. Again. അതും വിഷയത്തിനൊക്കെ ചെക്ക് എടുക്കാം. ഇതിനുള്ളിൽ അത് വിഷയത്തിനൊക്കെ ചെക്ക് എടുക്കാം. So basically, herpes zoster ophthalmicus is due to the varicella zoster virus. Varicella zoster virus. Now, chickenpox is caused by the same. Chickenpox, if you see, it comes all over the body. And once you get the chickenpox, it goes down after 14 days, and then the virus stays in the roots of the nerves. And then when your immunity goes down, it gets reactivated. And it comes and basically the the ophthalmic branch of the fifth nerve comes and supplies this area. And then it starts off by having vesicles. So the ophthalmic branch comes in and it basically comes on like that. painful vesicles, යාගෙන එන්නේ මේ හරි චුට්ටු චුට්ටු දෙනවා. You මේක පොඩ්ඩක් මෙහාට කරලා බලුවම you see the, if you see the first vesicle, you know basically that it's the real this thing is it doesn't go beyond that. Moment you see this, this is spot diagnosis. Cannot miss it. Very painful vesicle. One or two comes on, then it becomes a blister, then it bursts, and it's pain. Extremely pain. And it doesn't go beyond that. So it's varicella zoster virus, forehead, upper lid, and if the vesicle comes up to the nose and there's one or two vesicles at the nose, you call it Hutchinson sign. The importance of Hutchinson sign is that if there is a vesicle over here, the eye is affected. The moment you see that, you know that the eye is affected. This factor, elderly people who are immunocompromised, they are more prone to get this kind. And then the pain, the burning rash, everything is there. And how does the eye get affected? The Hutchinson sign is when the vesicle is right at the nose. And then you end up having a small keratitis and then an uveitis. And that's how and it's severe pain along that area. And when the complication in the eye is that, you get the keratitis and then there is iris atrophy because of the uveitis. And then you may end up having basically a keratitis and it goes on to the cornea. And then the iris atrophies. And because of that, you can end up having glaucoma. And if it goes into the eye, basically it can cause a pancreatitis also. But there is corneal scarring because if it's like that, you can have corneal scarring. The cranial nerve that gets affected are these things. And you may also have a retinitis. That means the retina can got defected. But the most important thing I want to tell you is when the vesicles go off and it gets all cleared up, you get what we call post-herpetic neuralgia. A persistent pain comes on this. Everything is gone. They are perfectly all right. Then you get a call from them, wondering the number and in their midst. Some people get so painful that they even want to commit suicide because of the pain. And that's called post-herpetic neuralgia. That goes on for ages, for years. So that is very important because you have to basically tell them eating because there you get pain. Then the most easiest and the most very successful treatment is those are the things that I was just showing you. And antiviral, we give them acyclovir. Very simple, very effective drug. Acyclovir. And you give them 800 of, normally we give them 800 milligrams 5 times a day for 5 days. That's the trick. Moment you see the first vesicle, you start them on that. There's no side effects, and the vesicle goes off, and that's it. If not, it comes and it leaves scars on this. Here you can see it's like they were scars sitting, and those scars never go away. The moment you get the one or two vesicles. About 1 month ago, our neighbor called me. She's in Malay. I'm having pain here. I said, you better come. I saw 2 or 3 vesicles. I said, this this thing, I mean, the herpes, you get this, and it didn't even leave a mark. No marks, nobody can even see that he got. So that's what I want to. So in an overview, the cause is reactivation of varicella zoster virus. It affects the forehead, upper lip, and then most commonly in elderly and in so as prevention, there is a vaccine. Herpes zoster vaccine, and it's normally recommended for immunocompromised patients. Good. Did you all like that? Good. I think that's it. Fine. You gave it marks. This is the first time I'm trying these out on your. Easy to try it on you all because normally if you give it in a huge this thing lecture I with the medical students, it's very difficult. Rheumatoid arthritis, systemic lupus erythematosus, venous lupus, and okay, thank you very much.